Moving forward to Plenary 7, the lecture by the Urological Society of Australia and New Zealand on options for Mitrofanoff urinary diversion, presented by Dr. David Winkle. I kindly invite Professor Ajit Malasekara and Dr. M. Shivashankar, consultant urological surgeons from Sri Lanka, to chair these rare and valuable sessions. Over to you, sirs.
I have great pleasure in introducing our next speaker for the Urological Society of Australia and New Zealand lecture. He is the immediate past president of the UAA and actually the first Australian New Zealand member to don this role, and he's also the past president of the Urological Society of ANZ. And he has extensive experience in reconstructive surgery with a special interest in pediatric neurogenic bladders. Over to you, sir.
Thank you, and thank you very much once again to Kalana and Manjula for inviting me to this meeting, which has been a wonderful experience both academically and socially, and I certainly will be amongst one of those who comes back with his family. Now, we've heard from Joe and Alan with a lot of science. Well, I'm going to change that a little bit in terms of my talk on Mitrofanoff and other catheterizable continent channels in an adult population. I do have a practice that involves both pediatrics and adults, and the pediatric practice in terms of the neuropaths and management of people with sort of congenital abnormalities and functional abnormalities segues well into my adult practice. So it was Dr. Lapidis in 1972 that first published a report regarding clean intermittent catheterization, and he revolutionized the way in which we treat people whose bladders fail for whatever reason and whose bladders may be toxic for them by introducing the concept of clean intermittent catheterization. Then in 1976, Dr. Mitrofanoff first performed a catheterizing channel using appendix, and he published a series of 6 in 1980. The concept took a little while to catch on, but now is a widely accepted concept. And I guess although we call it the Mitrofanoff principle, the other term that is used is continent catheterizable channels, so as not to cause confusion. Now, who needs a continent catheterizing channel as an adult? Well, there are patients who have bladder cancer, who have both bladder and urethra removed, who don't want a stoma. There are increasing numbers in my world, and talking to others amongst my colleagues, both in Europe, America, so-called Fowler syndrome, women who can't void, and many of those women also can't catheterize urethral. Many of them have been subject to sexual abuse, and the concept of catheterization is an anathema to them. So they present with the awful problem of inability to void, but an equally awful problem of the general paradigm is to catheterize urethrally. Go on, just catheterize urethrally, but they can't do that. And so for me, a number of patients present with this issue. The urethral strictures, both male and female, on occasion end up being treated with a catheterizing channel. It sometimes is the easiest way for some people to deal with a stricture, particularly from a patient perspective when they're offered a variety of options. Various developmental neuropathic abnormalities such as multiple sclerosis, transverse myelitis present with a poorly functioning bladder, often a contractile bladder, and again catheterization, particularly in the women, can be problematic. So a continent channel is often a good option. bladder exstrophy, both in the paediatric population, where there's often an attempt to reconstruct their urethra, but often as they progress into adulthood, the urethra becomes problematic for them in terms of catheterization, and they may well present in a situation where it's easier to simply build them a bladder channel rather than endeavour to reconstruct a urethra and a continence mechanism that's undergone 10 previous procedures, all of which have failed. They're left with a scarred, hopeless urethra. It's often easier just to close their bladder neck. As I say, people in wheelchairs, particularly women, often some of the women, particularly the congenital spina bifida and so forth, do change in their body morphology as they age, and catheterization is a huge problem for them. But even an otherwise healthy woman, similar to the one in the photograph there, often finds it technically difficult to maintain independence and catheterize urethral, whereas they'll present requesting an alternative to enhance their quality of life. Children who have undergone a variety of procedures, including the construction of a catheterizing channel, these channels often don't last a lifetime, and they do present needing revision, needing replacement, and so forth. So there are a wide variety of patients in whom this sort of surgery is a good option. Okay, so the types of options that are available, and I seem to have lost a slide there, one can use an appendix, which is the simplest, easiest thing to do, and is the commonest piece of tubing used in the paediatric population. Often in an adult population, an appendix is either too small to use, too difficult to move towards the bladder and achieve a cutaneous exit, and therefore unusable. So an alternative option for the adult population is the so-called Yang-Monty, where small bowel is reconfigured either into a single strip or a double strip to create a channel that can be catheterized. It's a good option, although the tip of each limb has questionable vascularity at times, and that can be a problem in terms of both stricture formation and difficulty catheterizing, in that if the tip that goes in the bladder is a bit ischemic, then it narrows and the patient can no longer catheterize. As well as Yang-Monty, there's the option of an isolated segment of ileum. It's a very simple, well-vascularized channel where the segment of ileum is taken. A 14 French catheter is passed into that segment, and then a staple gun is run along the antimesenteric border. It's very useful when a long channel is required, especially when there's been performed a bladder augment anyway. There are a few issues with respect to that channel in terms of staples at the stoma and the opening, and an increased incidence of urinary incontinence through the channel because of difficulties actually implanting that fairly bulky opening into a bladder. I should say those two sorts of channels are nominated as tunnelled channels. There is the non-tunnelled channels, where one uses the ileocecal valve or an intercepted ileum, such as the cock pouch. And my diagram on the right there is a representation of use of the ileocecal valve, where again the terminal ileum has a staple gun run along the antimesenteric border, and that achieves an excellent catheterizable channel, and that can be used in the sense of augmenting a bladder or even putting a patch on a reconstructed bladder. The challenge in using cecum as part of your bladder is, particularly in the younger population, a concern long term of malignancy in a colonic segment. Nipple valve mechanism, this is intersuscepted ileum. It's described as part of a bladder augmentation, a hemi-Indiana pouch, and Skinner, in their series of over 500 patients, used ileal intersuscepted nipple valves with 86% continence rate, which is outstanding relative to what I'm about to talk about in terms of results of Mitrofanoff and other continent catheterizing channels in adults. Bladder flap aren't a good idea. They invariably stenose, and that has been my experience in ureter. Ureter is a great channel. You're likely to get great continence. Unfortunately, the ureter, but to do it, you've got to put the other ureter on the other side, so unless you've got a poorly functioning kidney, it becomes a poor option. And ureter long-term, I think, becomes ischemic, and I've needed to replace a number of channels in this way. So complications of adult channels, and this speaks to what channel you might try and use when you're using one. Appendix channels versus ileal channels. Overall continence rates are a little higher because you can put an appendix into a bladder in a gutter and achieve good continence at that level. As I say, ureters, you get good results. This is a paper by Dan Wood looking at 176 patients, but of their 176 complete patients, 50% of them experienced difficulties catheterizing on a regular basis, and there was complete revision for either stenosis or incontinence, and that was higher in the ileal group than it was in the appendix group. But often they're different populations because you do have choices when you start the operation and once you've looked at what's available, and I think that speaks to the sort of lack of science in all of this, in that it's not an even population group. Veronica Fay did a systematic review of catheterizing channels in adult non-neurogenic patients. Now, ultimately, this was only, this was 220 patients that they accumulated from a number of series. Continence was 75%. You know, if you're incontinent, that's not a great rate. And stenosis ranged from 4 to 30%. Lowest rate of stenosis was recorded in the Indiana pouch, and the highest rate were in the Mitrofanoff and Casal type use of appendix. But the problem is we all tend to use that because it's available, it's relatively simple, and morbidity-wise there's very little happens rather than harvesting some cecum. So what's the best technique? The best technique, I think, is one that you get used to and you're good at, and you get used to the complications associated with that technique. Unfortunately, there is not a lot of science in terms of quality. There's not a lot of literature as to the quality of life that is obtained by patients with these channels, although as somebody who's performed this sort of surgery for the past 30 years, I think it makes a dramatic difference to the quality of life of people who in many ways won't catheterize. I had a small video which I can't show you, but this is a 2-year-old girl. Her mother I created a catheterizing channel for 25 years ago, and she's now had a little girl. Unfortunately for this little girl, she's got no idea how to pee because she can't go into the toilet with her mother. And in my short video here, which I unfortunately won't run, we see this little girl, and you can see the catheter on the floor there, and she's endeavouring to pass a catheter into her umbilicus as her toilet training, which I thought was quite a sweet reflection of the normality which this mother had basically had her child, and whenever she needed to void, she just went in and stuck a catheter in her tummy and drained a bladder and left the toilet, and this little girl had witnessed that, and that was her way of being toilet trained. So thank you for listening to me. I'll take the opportunity for inviting you all to the USANZ conference at the end of February, the 24th to the 27th, in Adelaide, Australia. Adelaide is a very nice city, and particularly at that time of year, particularly if you are a wine lover. Thank you for listening.